Around here. As a chiropractor, I'm very interested in pain, and especially the more natural ways of dealing with pain. My presentation, it's going to start out a little bit with the physiology of pain and the purpose of pain, and a little bit about chronic pain, and then we're going to move into basically just how the five senses and multimodal interactions in the brain can kind of override pain or decrease or increase the perception of pain. So let's jump in. So this is going to be really basic for some of you, especially if you're in a pain management background. But I tried to get kind of a middle ground here where it wasn't like too bogged down and technicality. It wasn't too basic. So in normal people, without a chronic pain syndrome, pain is a protective mechanism. So when tissue is damaged, we feel pain, and as an immediate stimulus, it can cause our muscles to contract and draw us away from the pain, just to keep us. So you touch a hot stove, you have an instant reflex to remove your hand, and actually there's the flexor extensor reflex here, where the painful hand will withdraw and then the other hand will extend. That partially has to do with your balance, so you don't fall over when you do that, and also has to do with old evolutionary concepts with four-legged animals maintaining balance and kind of jumping away from pain using, if you can imagine your hands as feet. And then it also stimulates these unpleasant regions of the brain in the somatosensory cortex that are telling you, okay, well, we got away from that now, but I just don't want you to ever do that again, so let's make sure you remember that that doesn't feel good, so let's not touch that hot stove again. Alright, so it serves a very important role in protecting the body, and as we'll see later, especially in chronic pain, pain can outlive its usefulness in some situations. Alright, so with the physiology of pain, how do we feel pain? So most tissues of the body contain these free nerve endings, and so they're especially in the skin, the periosteum, arterial walls, joint surfaces, the falx and tentorium in the brain, the connective tissue that separates the different lobes of the brain, the hemispheres of the brain, and the cerebellum. So they can be stimulated by mechanical, so blunt force, thermal stimuli, so if you get a burn, or chemical stimuli. So that can also be if you get a cut and the tissues release all these chemicals that actually ramp up the feeling of pain, such as bradykinin and proteolytic enzymes. These enzymes that break down proteins will kind of attack the free nerve endings, and that will ramp up your perception of the pain. So depending on the severity of the tissue damage, these chemical means can kind of tell you how severe the damage is, how much you should be worried about it. And so most other sensory receptors, the ones that sense the position of your hair, if you comb your hair one way, you'll feel it for just a few seconds, and then you forget about it. So most sensory receptors adapt over time. Pain receptors don't, and they typically don't stop firing until that painful stimulus is gone. So until that splinter is removed, or until the burn heals, you don't stop feeling the pain. So from the free nerve endings, a signal travels through the peripheral nerve to the spinal cord. And there are two basic types of peripheral pain fibers. So there's the A delta and C fibers. The A delta are the narrower but faster fibers that carry the sharp, usually mechanical pain. That's kind of like the instant sharp pain that you feel, like if you if you stub your toe, that instant pain you feel is carried by those A delta fibers. But then if you have a more chronic pain or a long-lasting burning, dull type pain, that's usually the C fibers carrying that signal. And those are the whiter fibers. That's basically what I said. Yeah, so the A delta are usually mechanical or sometimes thermal, and then the C fibers are going to be chemical or thermal. And I already said that. This is just a little diagram explaining, showing. Here you got carried in the dorsal columns. Here you have non-noxious mechanical stimuli, so light touch, just graphesthesia, feeling objects, feeling just normal, non-painful, non-damaging stimuli. And then the A delta fibers will carry mainly mechanical, noxious, damaging stimuli, and then the C fibers, burns, chemical, like harmful chemicals, that kind of damage to the tissues. All right, so these fibers will go to the dorsal horn of the spinal cord, and the signal will be relayed up to the higher centers, to the thalamus, which is the base of the brain. That's kind of the thalamus is sort of a primordial brain, kind of a less evolved part of your brain. So, and actually, when they separate the cortex, the more advanced part of the brain, from the thalamus, we can still feel this dull, burning, chronic type of pain. So they concluded that a lot of the awareness of the pain is not just in your cortex; it's actually deep down in the thalamus. So the C fibers carrying this chronic, dull, burning pain is much less readily localized. So when you stub your toe, you know exactly where you feel it. But when you have like a chronic low back pain, the patients will use their entire hand, so it hurts right, all in here, instead of saying right here. Like with a facet syndrome or facet joint pain, they'll point with their thumb or one finger, like it hurts exactly right here. That's usually the A delta fibers they're feeling. With the C fibers, you'll be able to say, this whole region of my low back, all the way up and down this whole area, this hurts. So this is just showing the different tracts. So there's the neo-spinothalamic tract. So it's neo meaning new. It's a more evolved, brand shiny, spanking new region of the brain. Spino, meaning spine. So it's a tract carrying these the A delta fibers from the spine up to the thalamus, and then the paleo-spinothalamic tract is the older, in the lower vertebrates. So it's kind of, just think of the way a worm would feel pain instead of a fancy human like us. Let's see. So the location, I already said this. So it's much more localized with the fast, sharp pain than with the slow, dull pain. And then at the level of the spinal cord, the pain is modulated, before it can even get to the thalamus. So you have these WDR neurons in the dorsal horn of the spinal cord. It stands for wide dynamic range. And so they are getting all kinds of input besides just the pain. So they're getting the stimulating input from the pain, but they're also getting mechanoreceptive input. So that's the non-harmful input, like feeling, moving your joints around. Joints are just lined with these mechanoreceptors that are sending these signals to the cord. And so the pain is a stimulating input, but there are all kinds of inhibiting inputs. So, so if there are enough inhibiting inputs, like if there's enough motion coming from the joints in the area and from the skin, like with a massage or with manipulation or these treatments we see like acupuncture, they all can kind of inhibit these WDR neurons. So if you get enough of those inhibitory signals, then you can block the pain before it even gets to the thalamus, so you don't feel it at all. So like I just said, if enough inhibitory receptors on the WDR neuron are activated, it will not fire and the pain signal will not be relayed to the brain. No signal, no sensation. So many physical modalities such as manipulation, acupuncture, massage, hot cold packs, exercise, they all provide those inhibitory inputs into the cord. So chronic pain, normally your body, you have an injury. Over time, your body heals, and then that stimulus is removed, so you stop feeling the pain. But sometimes, despite the fact that the body has healed itself, the pain persists. And this is usually due to central sensitization. That means that the central nervous system has been sensitized. So the brain and the spinal cord have lowered thresholds of firing. So most of the time with chronic pain patients, you'll see where you just lightly, barely press on their backs and they writhe in pain. And that's not normal. That's called allodynia. So allodynia is pain from a non-painful source, or a normally non-painful source. And hyperalgesia would be something that should normally be somewhat painful, but they have an over-exaggerated response to it. And so this has been studied. Chronic pain has a lot of research dollars going into it. So there's still many unanswered questions about it, but we have recognized several factors that play into chronic pain. Which of these are just correlated and which ones are helping to cause chronic pain, we don't really know at this point, but genetics, stress, anxiety, depression, inactivity, fear avoidance, and operant learning all play into it. Very commonly, chronic pain patients will see that they have very high stress levels, often on medications for anxiety and depression already. They tend to be inactive, whether that's before the pain started or after. If you have the hyperalgesia and the allodynia, you're going to be less likely to get out and start running if it's extremely painful for you. And then that leads into the fear avoidance, where they're afraid of the pain, they don't want to feel it anymore, so they kind of just sit inside and stop doing what they need to be doing to keep active. And so with the decreased activity, that kind of plays into a whole cycle where they get deconditioned. Their muscles aren't as strong as they used to be, so they're not supporting your joints anymore. So they end up with more stress on the joints, so that just ends up with more pain. And then operant learning, where a good example of this is they've done studies with MRI and with the language that physicians and healthcare practitioners use. So there have been some studies that show that patients who have MRIs and are shown some anatomical defect like degeneration end up with worse outcomes and end up with more susceptibility to chronicity, to their acute pain turning into a chronic pain. So a lot of it, there's a lot of psychology involved where if they're convinced that they have some defect, that there's something physically wrong with their spine, and that there's no cure for it, and it's always going to be like that, then for example, if a doctor tells them you have these degenerative changes and they're irreversible, what they hear is, I'm going to have pain for the rest of my life. So a lot of those beliefs play into chronic pain, where if you believe you're going to have pain for the rest of your life, then you might. Right, so beyond the initial modulation of pain at the cord, the body has many other ways of inhibiting or increasing the sensation of pain. So there's descending inhibition. So we have the periaqueductal gray and periventricular areas of the midbrain and pons. They send signals to the medulla, and from there down to the dorsal horn of the cord. And these neurons use enkephalins, endorphins, and serotonin. These are very, very potent painkillers, endogenous analgesics. And so they actually can inhibit both presynaptic and postsynaptic inhibition of the C and the A ductal fibers. So, and this is what opioid drugs mimic. They're very similar to these endogenous analgesic molecules. But the problem is, if you give this to a chronic pain patient and they're taking it for a really long time, the central nervous system will adapt. I tell patients, it's kind of like you see the athletes taking steroids, or bodybuilders taking steroids. You take that for a long time, then the testicles will shrink. The testicles just, they're supposed to be producing this testosterone, but your body, you're taking in all this artificial testosterone, so your body's like, oh, we have plenty of this, we don't need to make it anymore. So it's kind of the same thing. The periaqueductal gray areas will say, well, we have plenty of endorphins, so we don't need to make them anymore. So eventually you end up kind of killing off those natural pain-killing areas. So then when you try to go off the drugs, you end up with a lot more pain than you started with. All right, so as I mentioned, tactile stimuli can reduce the perception of pain, but what about the other senses? And there's a lot of really recent research that I found. Some of it was just published last month. And vision seems to be, it's at least the most studied of the senses other than tactile. Whether or not it's the most important for these multimodal processing tricks, but let's see. So when a painful stimulus is provided to one hand, they're looking at the painful hand with the arms crossed can reduce the pain. So they basically, for this study, used a laser to produce pain in one hand. And they studied patients who were, I think they had three groups. One was blindfolded, so they weren't looking at their hands. The other was just looking at their hands in a normal position, and the third was looking at them in a cross position. And the ones who were looking in the cross position had less pain. And so that, see, the way they explain it here is a complex interaction between cross-modal input and body representation and different spatial frames of reference. So basically, cross-modal input is talking about the different senses conflicting with each other, or trying to form a three-dimensional representation in your brain. So you're constantly, you're looking at an object. So you're using your vision to try to figure out what shape something is, how hard or soft it is, and you're using your hands to kind of feel, and you're integrating all these different sensations. I can hear also. So everything kind of comes together to form this image in your mind of what exactly is this object in front of me. And so if your vision and your your senses, your somatosensory tactile sense, you're seeing your left hand getting hurt, but you're feeling your right hand getting hurt. So your vision is conflicting with your tactile sense in that case. So, and then viewing the body can reduce the perception of pain. Let's see. So this has been shown in the laboratory and clinical settings, especially with phantom limb pain. I don't know if any of you have heard of the mirror therapy they do. I did an internship at the VA hospital back in St. Louis, and they did some of this with amputees. So you have an amputee with one leg, and they'll put a mirror so that they can only see the leg that they have and a mirror image of their leg. So they're moving around their one leg, and they're seeing two legs while they look down, and that somehow can reduce their phantom limb pain. Let's see. Yeah, so this experiment they used. Let me see. Yeah, so they had 3 different groups here. One where they just viewed an object, one where they viewed just the hand. Let's see. Sorry. So the mirror box technique, in which the subject has the experience of viewing their right hand while in fact seeing their left hand reflected in the mirror. But anyway, what they found was it was similar to that last experiment. They provided the painful stimulus using a laser to the hand, and the ones who were viewing their hand or a reflection of their hand felt decreased pain. They felt less pain. They're using with both of these, they're using EEG, where they actually measured the brain waves, and they use what's called laser evoked potentials. So that's kind of just how they work out the static of the EEG by providing a painful stimulus over and over, and then they just kind of can calibrate the EEG to that. Anyway, and this was another interesting one. In virtual reality, so they put virtual reality goggles on a patient and have them turn their head, and what they're seeing is either an exaggerated version where it actually looks like they're turning their head really far, or it's a decreased, like an understated version where it doesn't look like they're turning it as far as they actually are. And so these are all neck pain patients, or chronic neck pain and decreased range of motion. And so the ones who saw the overstated amount, who thought that they were turning their heads more, they stopped turning sooner because of the pain. And then the ones who saw the understated version actually turned their heads more than they normally would. So it really speaks to how important our vision is, and these pain thoughts, pain patterns that people have. And then this one was they used a rubber hand. So as you can see in the picture here, they covered up. They put a wall here where they couldn't see their right hand, and then they had a rubber hand under a blanket here, and then they brushed simultaneously. They brushed the rubber hand and their real right hand for about 3 minutes until they got the sensation that the rubber hand was their hand, because they're feeling it and seeing that rubber hand. So it's kind of like it's a body ownership disruption is what they call it. And then they put ice on their actual right hand, and that they felt decreased pain compared to just if they were looking at their real hand and feeling the ice. There's one more I didn't put in here. So it has to do with kind of the programming of the brain, feeling others' painful actions. These patients or subjects were they were shown videos of hands reaching out and touching an object, and then either just grasping it or recoiling in pain, and then they were asked to touch the object, and some of them were sharp or painful, but the ones that had seen the hand, like a video of the hand recoiling in pain, had a much exaggerated response on EEG. So if you have the expectation that something's going to be painful, then you're going to become biased in your brain that I'm about to feel pain, this is going to be bad. So hearing, now like I said, vision, there was the most research on that I could find, but hearing, I found a little bit on music. The functional imaging studies, fMRI, have shown that that music activates the primitive emotional centers of the brain and the descending analgesia system. So, so listening to music can cause a little bit more of that release of endorphins that can inhibit pain. And those primitive emotional centers and the limbic system all play into chronic pain. So listening to some relaxing music can be possibly be beneficial to chronic pain patients. Taste, I didn't find much on taste either, but there's a study that was focused around bulimia, but they found that in healthy women, the pain threshold is raised during eating sweet food. So eating sweets can make it so you can tolerate a little bit more pain while you're eating them. And the olfaction, smell, I really couldn't find, well, I did find a little bit on aromatherapy for adults, and then there's a lot on newborns with familiar scents. So they familiarized these newborns to a specific scent, and then while they were during an arterial puncture, they put a pad with that scent up to their nose, and they cried less. And then aromatherapy, there isn't great research supporting aromatherapy right now, but there's a possibility. There was actually a Cochrane systematic review that I found that you can neither confirm nor deny the importance of aromatherapy. But so that's all kind of interesting, but why does it matter? Well, here's some statistics. I'm sure some of you have seen these before, but Americans make up 4.6% of the world's population, but they consume 80% of the global opioid supply and 99% of the global hydrocodone supply. 116 million Americans suffer from chronic pain, more than diabetes, heart disease, stroke, and cancer combined. And chronic pain costs the U.S. somewhere between $560 and $635 billion per year. The more we learn about chronic pain, the more we realize that it's not a simple physical or chemical problem. It's a multifaceted issue that is unique to each patient. No single discipline or treatment has been very successful on its own. A multidisciplinary biopsychosocial approach appears to be the best course of action for these patients. Treatment should combine elements of medical pain management, physical medicine, cognitive behavioral therapy, psychiatry, nutrition, and evidence-based alternative therapies. That's it. Thanks. If there are any more
I have some questions. One of them is related to phantom pain.
Mm-hmm.
The presumption I have, being ignorant about the topic, is that it's all in, some cortical region or something like that. But there's nothing sensory going on. Is that actually the case? Is there anything that's like a feedback mechanism within the touch or any other sense?
Well, obviously, the nerve endings have been removed. There is no
Right.
no limb there. So I mean, although it feels like there is pain in this limb that they don't actually have, those areas of the cortex are still there. In your somatosensory region of the brain, there's what's called the homunculus, where there's certain areas for each part of your body, and so those neurons are still active in your brain. And actually, with some causes of pain, like your foot falling asleep with pins and needles feeling, it's actually more due to a lack of feedback coming from those areas. So you could explain it that way. It's really poorly understood, but a lack of feedback to those areas can kind of make bells go off, bells and whistles, alarms, or your body's like, wait, I can't feel this anymore. What's going on? You should try to move that around, try to get some blood flowing to that area.
Right, so in the case of an amputee, it makes sense, but people who are still intact and have pain, they just don't know that they're not amputated. I mean, you can feel pain in your hands for months.
Mm-hmm.
And, long after whatever the initial thing might have been.
Right. Well, yeah, it's really similar. Phantom limb pain seems to be really similar to a lot of the chronic pain syndromes out there, because with chronic pain and central sensitization, there's not really anything going on in that limb or that body part. It's all in the central nervous system. So, I mean, the phantom limb is a great example that really confirms that, because it's obvious that there's nothing going on in that limb, because that limb doesn't exist anymore.
So, do you think that our threshold for pain has been lowered, which is why 99% of opioids are used here?
I think a lot of it just has to do with
I can't imagine that's
with management. I mean, there are multiple factors that there's the pharmaceutical companies for years kind of shoving these drugs down the throats of physicians, and I think just American medicine has chosen a different way to manage chronic pain. It's not that chronic pain doesn't exist in other countries.
So, what would the common usage in Europe be compared to what we do here? Because, I mean, they have great medicine there as well.
I think in Europe it's more, they focus more on the education of the patients, telling them, ways to deal with the pain, or working out more natural or less risky ways of dealing with it. So I don't know. It would be interesting to talk to a European pain management physician.
Do they have those?
I assume so.
What percentage of total use of opium goes to to the drug opium, as in the drug heroin, or opium as it's smoked?
I don't know.
Is it a small percentage?
You can smoke with you.
Oh, yeah. It's commonly done.
Uh-oh.
Yeah.
You don't know that?
I don't know.
Not our good.
You prefer the needle, I understand.
Yeah.
No, but I'm just curious, because is it like 1%, 0.1%, or 50%? It just seems, because you always hear about how lots of people are taking illicit drugs and.
Well, I did see a statistic that the U.S. consumes, I think, 2/3 of the world's production of illegal opiates.
Illegal?
Yeah.
Good lord.
Can I ask,
Mm-hmm.
I get chronic muscle cramps in my feet every day, almost, wake up several times at night. And it's really, and the doctor prescribed vitamin D for it. How does it help, and that's one thing. Second thing, what we did was, not for that reason, but we put in a humidifier in our bedroom. We missed a humidifier, and it seemed to have helped.